To John Bennett, broadcasting from Miami, Florida. Tonight we have a continuing in the series of hangouts about Parkinsonism from world-renowned neurologist from Toronto, Dr. Abdul Rana. And tonight we're going to cover motor symptoms of Parkinson's disease. Good evening, Dr. Rana.
Good evening, Dr. Bennett. How are you doing tonight?
Very good, very good. I see you have snow in the background there. It's all white.
It's slowly melting, but it's still very cold.
Okay, very good. Yeah, it's kind of chilly in Miami too. Anyway, let's start right off. What are the main motor symptoms of Parkinson's disease, and how do you test for them?
The most important motor symptom of Parkinson's disease is slowness of movement. So most patients would present, or they will come with their family members or spouses, complaining that these patients have become slow in doing things. They take much longer to complete their daily activities, such as eating, dressing, and they cannot finish on time. So this is most common complaint of the patients. Sometimes these complaints could be considered as part of aging if the patients are elderly. This slowness of movements we refer to bradykinesia. It's one of the most cardinal symptoms of Parkinson's disease, and the diagnosis in the diagnosis of Parkinson's disease it has a particular importance. When patients come to see us, we ask them several questions to determine if they are slower than normal or slower than before, or if the slowness has a clear onset. Like we would ask them to compare themselves about a year or a couple of years ago before they notice slowness of movements. So when these patients come, we ask them to do certain movements, such as rapid fist clenching, like opening and closing their hands, finger tapping, rapid turning of their hand side to side, and we look at their speed of movements, their amplitude of movements. We sometimes ask these patients to tap their heel or their toes on the floor repetitively. So the amplitude of the movements becomes less with time. The speed of movements also becomes less with time. They fatigue early when they are doing these movements. So this gives us a clue that they are slower than normal. And usually, because Parkinson's disease starts on one side of body, the one hand or the one foot is slower. The finger tapping or the opening and closing of hands or hand turning on one side would be slower when you compare to the other side. Similarly, the leg agility movements like the heel tapping or the toe tapping is also slower when you compare it to the other side. If it is subtle in the beginning and if the patients are otherwise healthy, relatively younger, then we might ask these patients to shrug their shoulders repetitively, and we look for asymmetry. Now, when you examine these patients, you have to be careful about the handedness. Like if patients are right-handed, which most of us are, so their movements on right side would be relatively faster as compared to the left side. So you have to discount that during the examination. If Parkinson starts on right side and patient is right-handed and their right-sided movements are slower than left, then it gives you a bit more assurance that they are right-handed. They should be faster on right side as compared to left side. But now when you see them, they are slower on right side, which helps you determine that they are bradykinetic. The other complaints these patients may have that they would say they have trouble fastening their buttons or cutting foods or fruits or tying shoelaces or putting socks, maybe a challenge, and they start taking longer for these tasks, or sometime when the condition is a bit advanced, they may need the help of spouse or family member to do these tasks, which is also indicative of bradykinesia. So in addition to these, there are several other indicators of bradykinesia because it could manifest in many different ways. The voluntary movements become slow, the speed of voluntary movements, the amplitude of voluntary movements also becomes less. As I said before, they fatigue early and easily with repetitive movements. And also, sometimes they may have a delayed initiation of a movement. If you ask them to do finger tapping, they would take some time to start finger tapping after you have told them. And at other times, some patients would present with micrographia. They would say that their handwriting has become slow and small. I had a patient who was doing reasonably well, and he had no symptoms of Parkinson's disease otherwise. So he went to the bank and he signed his check. So the bank teller somehow thought that his signatures were different from previous, and when they compared, they were quite smaller. So she has to check his ID, and this is how he realized that there's a change in his handwriting. So he decided to see his family physician, who noticed some more symptoms, and therefore he was referred to our clinic. Sometimes the families would bring them, and they would say that they just stare. I had a patient whose spouse said that he just keeps on staring. He does not blink his eyes, and he's sitting quietly, relatively quietly. So decreased rate of blinking, lack of facial expression, these are also signs of bradykinesia. Some patients would have difficulty rising from a couch, like if they're sitting on a couch for some period, and the couch is especially deep-seated or on a chair, and they stand up, they would be slower to stand up, and at other times they may take more than one attempt. So they start rising slowly, which becomes a bit alarming to them or their family members. So other patients could be noticed by their family members that they walk in a different way. They would say that now they take short steps, their gait has become sort of shuffling, and if husband and wife go for a walk daily, some people have a routine, and one of them is left behind because he's walking slowly, so the other one would complain that he cannot keep up with the walking when we go for a walk, and he takes much longer to catch up. So slowness in the speed of walking is also indicator of bradykinesia. Sometimes patients just don't stop swinging their one arm on the side of Parkinson's disease. They would be walking, otherwise their speed of walking, stride is good, but just they are not swinging their one arm. They might think that this is their habit, but they had never done this all their life, so it kind of makes them concerned. I had a patient who met his wife at the age of 21, and the wife the first time met him at the age of 21, and she noted that he did not swing his arm. So she did ask him this question, that when you walk, you don't swing your left arm. So they kind of ignored. Of course, they were not aware that this could be an indicator of future Parkinson's disease. So this patient was diagnosed first time with Parkinson's disease at the age of 37. So it could, in some cases, the arm swing could start much before the other symptoms of Parkinson's disease. I'm not sure if he really had other symptoms of Parkinson's disease at that age, which is less likely, but his wife was so clearly remembers his decreased arm swing that when he was diagnosed and we discussed these symptoms, she said, "Wow, I had noted this lack of arm swing when he was 21, which was 16 years before the diagnosis of Parkinson's disease." And so these various and diverse manifestations have to be screened by the physician. The physician has to ask the patient about these various manifestations of bradykinesia, because patients may not be aware. Or in elderly patients, as I said, they could be taken as because they're getting old, or they have arthritis, or just they could ignore these symptoms. So bradykinesia, as I said, it is one of the most important and cardinal symptom of Parkinson's disease, and has a key role in diagnosis of Parkinson's disease. And other symptom which patients may not be aware, and you could say that it's more like a sign, is rigidity. So these patients have stiffness, and stiffness of the muscles is usually on one side of the body, or if it is on both sides, it's usually more on one side of the body, as the onset of Parkinson's disease is asymmetrical. So these patients sometimes may notice some tightness in their arm, but when you examine them, you would find some increased resistance to passive movement at their wrist or at their elbow, and in advanced cases, this could affect the lower extremity as well. So sometimes this could be subtle, and you may have to ask patients to open and close the other hand to make it more apparent and more noticeable during the examination. Some of the patients could have subtle cogwheeling, either without rigidity or with rigidity. In elderly patients, mild cogwheeling without rigidity is not uncommon, and therefore one should discount this if they don't have other symptoms of Parkinson's disease. The amount of resistance offered by the muscles of these patients remains the same, even if you increase the velocity of movement or decrease, which is in contrast to spasticity. In patients with spasticity, which is more of seen in stroke or MS, because this is pyramidal in nature, as compared to rigidity, which is extrapyramidal symptom. So the tone of muscles increases with the speed, and you feel a catch type of feeling at the end of the movement. And more you increase the speed, more tone you would notice. That would be spasticity, and I always ask my students to be quite careful when they are interpreting these symptoms, to keep rigidity and spasticity in their mind when they're examining, and also a mild cogwheeling. They could discount that if patients are elderly and they don't have any other symptoms of Parkinson's disease. The rigidity should be tested not only in limbs but also in neck, because Parkinson's disease patients, with the time, they could develop rigidity in their neck, and sometime in the beginning they may have a subtle rigidity in neck, which is tested by a gentle side-to-side movement of neck by the examiner. One important difference of idiopathic Parkinson's disease from the atypical Parkinsonism, such as progressive supranuclear palsy, is that the rigidity in the limbs is more as compared to axial rigidity in idiopathic Parkinson's disease, as compared to progressive supranuclear palsy, in which the rigidity in the neck is much more than the rigidity in the upper limbs. So, as I said, the rigidity is also asymmetrical, and sometimes patients may not be aware of this, and when you test these patients, you find out that they have stiffness, which could be subtle in some cases. Another important symptom which brings patients to attention is a resting tremor. So resting tremor is something which prompts patients to seek attention very quickly, as compared to bradykinesia or rigidity. As I mentioned, some patients may not be aware of rigidity, and other patients may discount bradykinesia or slowness of movement as part of aging. But when these patients start having a resting tremor, so they feel quite concerned that they start noticing sometimes their thumb is shaking, or their index finger and thumb are shaking. So in the beginning, the resting tremor is usually on one side. It affects mostly upper extremities, hand, and the movement could be supination, pronation, which is side to side, in other cases, it could be flexion extension, like up and down movement. Most patients with Parkinson's disease, they have side-to-side movement, which is supination, pronation, and very few patients have flexion extension movement, which is usually seen with action tremor, which is present in many other conditions. So in case of resting tremor, because the thumb and index finger is moving and then there is a supination pronation happening, when you see a patient with this type of tremor, it seems that they are making a certain movement which sometimes is referred as a pill rolling tremor, because their hand moves in a way that they seem that they may be making pills of with their hand of something. So when you see these patients, it's quite reassuring that the diagnosis is Parkinson's disease. The resting tremor could involve the other side with time. Sometimes patients have tremor involving leg. The leg tremor is only examined when when patients are either lying down or they are with a complete repose. If they are rested, their legs are dangling. The resting tremor of legs should not be present when they are walking or when they are stretching their leg, holding in space above the examination table. The resting tremor in most cases of Parkinson's disease is of low frequency, which we refer between 3 to 5 hertz in the beginning of course of disease. The frequency, however, is somewhat variable. If patients have a low amplitude tremor, it could be a little bit more in frequency, and if the amplitude is high, then the frequency would be low. With time, these patients may develop action tremor, like when they are holding their arms in front of them or holding things. In advanced cases, they could develop the action tremor, but in most cases of Parkinson's disease, the action tremor appears after a certain latency when they outstretch their hands, and also it appears after the onset of resting tremor. We are talking about most cases, like many generalized things, but always exceptions happen. Some patients could be presenting with the action tremor in case of Parkinson's disease. So the tremor is a rhythmic movement. It's an alternative rhythmic movement, which is by the contraction of the opposed muscle groups simultaneously. The resting tremor of Parkinson's disease could be quite embarrassing socially, because patients are sitting relaxing. Suppose if they go for a dinner, or they are with their family members, or they go for a social outing, so their hand is shaking, and which is very obvious. Although when in the beginning of Parkinson's disease, when they try to hold on to something, the resting tremor disappears. So in the beginning, it's less disabling than the pure action tremor, but socially it's a bit more bothersome as compared to a pure action tremor, which is present only on action, and when a person is resting his limbs, then the action tremor is not present. So they don't get bothered socially unless they are holding on to things, as compared to the resting tremor. So, as I said in the beginning, it could be very subtle, the resting tremor, and you may have to do certain mental tasking to stress them out. Like if a patient is having, if a patient you are examining for Parkinson's disease and you don't see their tremor, so you should make them lie down or sit with a complete relaxation. And then if you ask them to recite the months in reverse, like starting from December, November backwards. So this mental stressing does bring out their tremor. Or if you ask them to count backwards, do serial sevens, like count from 100 backwards, they would be stressed and their tremor becomes more apparent. The tremor of Parkinson's disease could also involve chin or lips, but it usually does not involve head or voice in most of the cases of Parkinson's disease. About 2/3 or more than 2/3 of patients usually have a tremor at presentation, and some patients may not have a resting tremor, and hence sometimes we we divide Parkinson's disease into a tremor-dominant Parkinson's disease. If the tremor is very severe or very prominent, and other symptoms such as bradykinesia and rigidity are subtle. So from prognostic point of view, we say that this is a tremor-dominant Parkinson's disease, which has a better prognosis as compared to non-tremor dominant Parkinson's disease in the long run. So sometimes to the patients, when they complain of tremor, there are some patients who would say that if you see them first time, give them medications, especially levodopa, and their tremor does not improve much, so they would come next time saying that, well, my tremor has not improved. So I tell them, well, yes, I told you the tremor may or may not improve. It does not improve completely, and sometimes I do tell them in a joking manner that you know, tremor is a good thing to have with Parkinson's disease, because in the long run, the prognosis is better, and then they become satisfied. Because as compared to those patients who don't have a tremor. So sometimes I tell them that if a person was given a choice between two types of Parkinson's disease, with a tremor and without a tremor, I think if they don't have a choice, they should go head for a Parkinson's disease with tremor from the prognostic point of view. So another problem we see with Parkinson's disease is trouble with balance, postural instability. So this symptom usually appears later in the course of disease. In the beginning of the onset of Parkinson's disease, patients feel their balance is fine. They don't have major issue with postural reflexes. However, they may have somewhat bent over posture at neck or at their knees, but they still can walk reasonably well, and they can maintain their balance. However, with time, they may notice the stride length shortens, their base becomes narrow, their speed becomes slow, and turning becomes difficult. And some patients may have freezing of gait, which we'll talk in some other hangout. So these changes in the posture of patients, speed, and their reaction time, they lead to trouble with their balance. So these patients start noticing that they can't maintain their balance after a couple of years of having Parkinson's disease, which does worsen with time. And when these patients come, we in addition to taking history, they do a test which is commonly referred as a pull test. So in this test, patients are told to stand firmly with their feet apart, as firmly as they could, and then they are pulled suddenly backwards from their shoulders. And the examiner is always there to support them in case they were to fall and could not maintain their balance. So patients who have impaired postural reflexes, they are not able to hold on to themselves, and they will fall on the examiner. But other patients would they would be able to hold on to themselves even if the examiners pulls them quite hard. So some of these patients may have trouble with their balance when they try to sit in chair, and as I said, this trouble does not occur at the onset of disease. And other patients may have something called fascination. So these patients are also sometimes brought by their families, and they say that they run and instead of walking, and they keep on running, and they can avoid any obstacles to avoid falling. So I had a patient who indeed once reported to me that he was trying to catch a bus when the bus was leaving. So he started running, and when the bus left, he could not ride in the bus. He could not stop running. He kept on running till he hit a pole and fell down. So this is how he was brought with a fall. But when we examined him, he had other features of Parkinson's disease. So fascination is a quite well-known symptom of Parkinson's disease. It's very typical for Parkinson's disease. And even James Parkinson, who described first time shaking palsy, he described fascination as well.
Very good, doctor. I think you answered a couple of my questions. One, and maybe you want to comment some more about every patient having tremors. And you mentioned that 2/3 of patients have tremors, approximately.
Right. Right. So most patients do have a tremor, which is resting tremor. It starts on one side and involves mostly upper extremities. But about maybe 30% of or so patients may not have a tremor with Parkinson's disease. And sometimes, very interestingly, patients would comment that when a patient does not have a tremor, you see them, you examine, and then you diagnose them. So they would say that, well, I don't shake, I don't have tremor, so how come I have Parkinson's disease? So tremor is such a well-known symptom of Parkinson's disease that people take it, they take it equivalent to Parkinson's disease. If they have tremor, we think they got Parkinson's. On the other side, there are some patients who have action tremor, such as those with essential tremor, and they would come to be assured if they don't have Parkinson's disease.
Yes, well, maybe you could give me a breakdown of what percentage approximately of Parkinson patients have bradykinesia. Approximately, I know it's probably not exact.
Yeah. Most patients with Parkinson's disease would have bradykinesia. However, they need to be examined very carefully. You need to examine them, you need to stress them, and also you look at very carefully. Even the side which does not apparently seem to be involved, on that side you can maybe assess for subtle bradykinesia which is present. And some of the experts, I'm still a student of movement disorders and neurology, and I'm learning various aspects of Parkinson's disease. But some experts do think that if a patient has bradykinesia and in addition has one of the symptoms of rigidity or a tremor and a response with a response to levodopa, so they would consider them to have Parkinson's disease. So bradykinesia takes a very key position in the symptoms of Parkinson's disease.
What percentage approximately do Parkinsonism patients have rigidity? Do 100% patients have rigidity?
I think majority of patients would have rigidity, but again, you have to reinforce it with the movement of the opposite hand, and you have to examine very carefully. But subtle rigidity, you can make it apparent during examination.
Yeah, during your last couple of talks, you talked about the varying clinical scenarios where patients are initially diagnosed with Parkinsonism, and I find it very interesting. You mentioned tonight one patient writing a check caused him to be referred to his family doctor. Another patient, arm not swinging. Another patient with running too fast to catch the bus. So patients present with all kinds of different presenting symptoms.
Right.
It seems. What are the most common presenting signs of a patient that eventually is diagnosed with Parkinsonism?
I think it's still resting tremor, because resting tremor is such an obvious sign that patients notice it, and families notice it, friends and co-workers notice it, and it's quite concerning when a person is resting their hands, not holding something, and they start noticing their fingers. They may not call it a tremor, they usually call it twitching. They say, well, my hand is twitching, my thumb is twitching, your finger is twitching. So that type of twitching, according to the patients, is likely the most common symptom of presenting to Parkinson's disease clinic.
Okay, doctor, that's a pretty complete coverage of the motor symptoms. Any more comments before we close on the motor symptoms of Parkinsonism?
As I was talking previously, the balance problems usually come in 10 to 15% of patients in the beginning of course of disease. So if patients don't have balance problems, the physicians should not discount their other symptoms, because sometimes people do think that if they don't have balance problems, so how come they have Parkinson's disease? So yes, these problems occur in the later course of disease, not in the beginning. And in the beginning, only 10 to 15% of patients may present with postural instability.
Very good, Dr. Rana. Another good talk on different aspects of Parkinsonism. Thank you very much.
You're welcome. Thank you. We'll see you again.
Okay, this is Dr. John Bennett broadcasting from Miami for Parkinsonism TV. Today is February 15th, and we'll be seeing you most likely tomorrow night. Thank you.